questions at the beginning, the first few slides of the PowerPoint. But what you have in your hand, or are getting in your hand, is methods for doing dosage calculation. And there's 4 different ways, and basic formula, ratio, proportion, fractional equation, and dimensional analysis are all different ways that you can reach the same conclusion. And everybody does it a little bit different. Find the one that works for you. Okay, and so we'll go through each one of these using the same math problem, but I want you to kind of write it out and see if that works for you in your mind. The one benefit to the dimensional analysis at the very end is if you have to do conversions within a problem, like if you have to go from grams to milligrams, you can do that in the equation versus having to do that before and then put that information in the equation. So whichever way works for you, works for you. So if you want to go from, if you need to get it to milligrams and they give it to you in grams, if you want to switch that to milligrams before you ever put the information in the equation, the first 3 will be fine. And some people need to do it that way because it's too much when you get it out into this huge long equation. Other people need to do it in the huge long equation and have it that way and mark everything out. So whatever works for you, use that. We all do different things when, even amongst ourselves as faculty, when we do math problems. And so by all means, ask people. If you're struggling and it's not me, ask Nancy, ask Caitlin. Caitlin's a math genius, so she is really good at it. If you want help, I'm sure she'd be willing to help you with that as well. Michelle and Jamie and Kristen can all do it too. We all had to do it. So the problem that we're going to work through is this one here. A patient is due for his antibiotic dose. The order states 500 milligrams of amoxicillin PO BID. So what that's saying is this patient is going to get 500 milligrams of amoxicillin by mouth twice a day. BID is 2 times a day. Available is a bottle of amoxicillin with the following concentration: 250 milligrams and 5 mLs. I look at this equation and I don't even need to do math because I can just get to the problem because this is easy. Do you guys see that? You're going to get 10 mLs, right? Because there's, right. So, this isn't, we start with an easy one for a reason. So it makes it, y'all know you're supposed to get to 10 mLs. And if you don't, you will. If you look at your sheet, it's going to define a couple of terms or a couple of letters. The D is desired dose. So that's what you want to end up with. Your desired dose is 500 milligrams. What you have on hand is 250 milligrams. Okay? The vehicle or quantity is the amount that what it's dissolved in, which is 5 mLs. Okay, so you have 250 and 5 mLs. The dosage on hand is 250. The vehicle or the quantity is 5 mLs. Do you understand that? That helps. And then X is what you want to get, what you're solving for is the amount to give. So if you look at the first basic formula, it's the D times V over X, or over H equals X. So the desired dose is 500 milligrams. So it would be 500 milligrams. I printed this off for a reason. I take it, this is in the back of the room here. So your D is 500 milligrams. Is 500 milligrams. What you have on hand is 250 milligrams times your V is 5 mLs. Okay, when you administer this medication, you're going to administer it in milliliters. Does that make sense to everybody? You're not, because the 250 milligrams are in milliliters. And you'll see this a lot when you give liquid medications or when you give IV push medications. We're not giving the milligram, we're actually administering the milliliters. I see some nods. Is there anybody that's like, they lost me when you say that? Okay. So, this equals your X. What's 500 divided by 250? 2 times 5 is 10. Does that make sense to everybody? Okay, that's the basic formula. That's an easy one. And I actually did it right. I put it on the right way. I did it in front of you guys, and because I do it in my head, I don't do this that way. Pretty sure this is not clear, but it works really well. Okay, so that's basic formula. So kind of write that down. Yeah, write that down on your paper so you have that. The next one is ratio proportion. Here is just working through the math. 2. This is ratio proportion. So what's your H? What's your, remember your H is what you have. It's still the same problem. What's your H? 250? What's your V? 5 mLs. 5 mLs? Your dose, what's your dose on hand?
What's your desired?
What's your desired dose?
500.
500? And then you're solving for X. And here, you multiply and multiply. Okay? So you're taking the insides and you're dividing it by the outside. So what's 5 times 500?
2,500.
Divided by 250. Does that make sense to everybody? So you're multiplying and dividing different numbers, but 250 into 2,500 still equals 10 mLs. You with me? So some people may like that method. No. This is the least popular method, but there may be somebody out there that this really works for them. There will be no jurors on this. I'm afraid of my white or like disintegrating the stuff that's on it, but that's okay. It's not great. Okay, so then you just walk through this. Okay, the fractional equation. What's your dose on hand? Sorry. 250 over your vehicle. 5. And then your desired dose is
500.
and over X. I guess I should tell you what form so you can see how that works. Okay? Then you cross multiply. So some of you guys have done this. And you still get the 2,500 divided by 250. It's just a different way of putting it, which is 10 mLs. Okay? So that is another way. And you can just put it, set it up differently. Okay? I want to show you the dimensional analysis. It looks very similar to what you just did. Okay. X is what you're solving for, and you're taking the vehicle, the 5 mLs, times the desired dose. So your X equals your 5 mLs times your desired dose
500.
divided by 250. That's a number. The reason why this works, you still get to 10, if you didn't know. You still get to 10. It didn't change the answer. But I do want to, does that make sense to everybody? This is the one that you can add stuff in, because you can mark out mLs, or you can mark out milligrams. And so you're left with the mLs, which is what you want. Okay? And you can kind of do that in some of the other ones. Here's where this one is helpful. Okay. If the order was written in 5 grams, 0.5 grams, that's still 500 milligrams. Does that make sense to everybody? But it's written in 0.5. So if I had this, I could just add this in 1,000 milligrams, or 1 gram is 1,000 milligrams. And then I could still mark everything out and end up with just my ml. Is that's where this comes in. And when we do pediatric, because we're gonna move into pediatric calculations, a lot of times they'll give you a weight of a child in pounds. And in order to do drug dosage calculation, you've got to flip that to kilograms. And so if you even had a patient that weighs 60 pounds, then you could further come out here and do in 1 pound, or in 1 pound, there is 2.2 kilograms, and you have 60 pounds, and so you would mark out, and you could get there. Or you can just do this before and put it in a different equation, which is, that's how, this, it's too long for me. It's too many steps. I'd rather do my conversions first and then put it in a simpler equation. Yeah.
You don't have to, like, do all these other tests, right? We just do it however we do it.
You can do it however, as long as you get to the right answer, I don't care how you do it. Because there's a lot of times, like that first, if I would've gotten that first, like the first question, I would have not even done math. I would have just multiplied like 2 and got there. And I wouldn't have written it out. So I don't care how you get to the right answer, as long as you get to the right answer. If you can't get to the right answer, then we'll have to work more on it. The biggest issue that students have when they do math is they forget to do all the conversions. So they forget to move from grams to milligrams, and they try to put the 0.5 in the equation and it doesn't work. So make sure that you're in the right, if it's asking you that it's 0.5 or 0.5 grams, but you only have milligrams available, you've got to switch it to milligrams. Does that make sense to everybody? If you have a child's weight that's in pounds, you've got to switch it to kilograms. So that's the biggest thing that trips people up. Okay? It's all dead. Yes?
So when you, is that only for pediatrics? When
No.
you- Or do you have to switch to
You do.
kilograms whenever you do?
Everything. We never calculate drug dosage in pounds. We always calculate in kilograms. So that 2.2 pounds per kilogram is something you'll use all the time. When you get into critical care, you'll do dose per kilogram per minute. So like milligrams per kilogram per minute for most of the medications that you titrate on critical care patients. So here's what I'm going to tell you guys about math. Electronic health records have made this, and smart pumps have made this a lot better for you, because they will do a couple of different things. Your electronic health record will show you the exact amount that you should be giving your patient. When you pull it up, it will tell you. If it is this equation, it will tell you to give 10 mLs. On a smart pump, and I'm talking about an IV pump, if you're hanging a drip on a patient, depending on the medication that you're giving, there's a range that's appropriate for that. And so when you go in and you work on the floor for the first time, if you're in critical care or NICU, you'll select that parameter. Meaning I'll select critical care, I'll select NICU, or I'll select med surg. Because there are certain medications that, based on the unit that you work in, you shouldn't even be able to give. So like if you're working on a med surg floor, you should be able to titrate Levophed. And it won't let you even put it in the pump. That's a safety mechanism. That's to tell you, whoa, you shouldn't be doing this. Does that make sense? It also will give you a therapeutic range for that medication. So if you try to program that pump outside of what it should be, it won't let you run it. Okay. Understand that. It's still a human that's putting that in. A pharmacist or somebody has entered that into the computer. Somebody has programmed those pumps. The pumps are a little bit better because we use them all the time, and so most of those kinks have been worked out. And pharmacists are phenomenal about math and drug dosage calculation, but they're doing that 100 times a day. And so don't just assume that that is the right dosage of medication, because you would feel sick if you gave it and then turned out, oh, I made the math, you know, as a pharmacist, I made the med error and entered it wrong. So still check, and make sure that that is an appropriate dose, especially when you're dealing with kids. Because you'll give such small, tiny doses, and if you give them the wrong dose, it can really, really harm them. And so I'm sure that Caitlin will go over that a lot more when you guys get into peds with her. She has some stories that she'll tell you. Did we start this? Did you? Okay. I told you I'd tell you and I didn't. So just be prepared for that. Math. Questions about math? Anybody have questions about math? For this. This will be on exam 3. Okay? Not next week, so we'll test the following week, we'll do peds calculations, so we'll add that pounds to kilos into this. It's the big thing that goes into there. The other thing is a lot of times you do those, when you hang drips for kids, we go from hours to minutes. So when you hang an IV fluid, you run it at like 75 milliliters an hour. In children, a lot of times we run it per kilogram per minute, and so you'll have to do that. And I think all of you know that there's 60 minutes an hour. That's probably an easy conversion for you. Okay? And then the next week, I think, which is after fall break for you guys, these are both, is we'll do IVs. How do you get to what rate you run that at? If you have 1,000 cc's and you want to run it in over 10 hours, what would you set your pump at? If you have an IV and it's running at 175 cc's an hour and you have 1,000 units or 1,000 milliliters to infuse, how long will that take to run in? We'll do those types of things with you. Okay? Make sense?
So what math is on this exam?
Conversions and military time are fair game from here on out. Okay? And then we'll do I&O and we'll do drug labels. Did you guys do your I&O calculation? I need that.
Oh,
Nancy has them? Okay. I'll get it from you. And if you calculated that right, and you should have calculated it right, because you guys should have gone over it together in your simulation group. So that's it. I&O, drug labels, and there's an I&O problem, there's some identification on the drug label, and then there's some conversions and some military time because it was heavily missed. Military time, there's a couple of you guys that missed military time too. So review military time for sure, because you will use that extensively in healthcare. Okay. Some of these that you guys will know, when I talk about, we're gonna talk about Tylenol, we're gonna talk about aspirin, we're gonna talk about ibuprofen, because we do give those in practice. But we're also gonna get into your opioids, your opioid antagonists, which is a lot of times used for either withdrawing a patient from an opioid or as a reversal agent if somebody has an overdose. So we're gonna talk about that. And then at the very end, we'll talk a little bit about some meds you can use in addition to opioids that kind of can help with pain control, especially if you have somebody that's got chronic pain and migraines. We used to give opioid pain medication for migraines in practice, and we don't do that as a rule anymore. There's better choices for that. What they found is when somebody came in with an acute migraine to the ER and they are in pain and they're vomiting and they feel terrible, we give them a big dose of narcotic and it would put them to sleep, and then they wake up with a rebound worse headache. So they may give them a little bit of narcotic, maybe, but most often they're giving them a cocktail of other medications to control that in practice now. Pain and inflammation go together. Because part of that inflammatory process, when you have an injury to your body and white blood cells and your vessels start to dilate, fluid starts to move into that area to help fight that bacteria or cut or whatever it is, that inflammation in and of itself presses on nerves and can cause pain. So when you give somebody a steroid or something to decrease that inflammation, that can actually work twofold, but one of the benefits of that is to help with pain control. So most of the pain medications that we're going to talk about are going to hit somewhere in that pain transmission pathway and that inflammation cascade. It's going to block prostaglandins or different receptors on skin and nerve cells in order to block pain. I don't like that. So just to remember, the inflammatory response, a few things that it does, and you guys talked about this in Patho, correct? Like this isn't new, right? Monday mornings is the worst time. It really is. Histamine and prostaglandins are released. Histamine and prostaglandins do a couple of things. It causes your capillaries in those tissues to vasodilate, so they get really big, they rise to the surface, and they get very, very permeable or leaky, so that whatever we have in our bloodstream that's going to help fight that infection can be released out into those tissues. And this actually spurs the clotting cascade. It releases products that will initiate that clotting cascade too. Because if you get a cut, you not only want it to get white blood cells there to help fight that infection, and blood flow, you also want it to clot off so you don't just keep bleeding out from that cut or wound. And this is true whether it's external or internal. If I have a bacteria that's entered into my system internally, I still want to fight that infection. And it still happens the same way. If I get a lung infection, those capillaries in my lung are going to dilate, move to the surface around where that pathogen is, and become leaky. So I can get what I need to that area of my body to fight that infection. And that can cause pain. That inflammation in that area can cause pain. So just a kind of a little bit of a review of the inflammatory response and how that happens. This is the pain pathway. Have you guys talked about this in health assessment? Did you talk about pain pathway at all in health assessment? I hear some no's, some yes. Okay. Transduction, transmission, modulation, and reception, or perception, are the steps of the pain pathway. So basically in transduction, when something enters my body, or whenever I would poke Jeremy with, if I go in and stab him, the pain receptors at that localized area, the surface of my skin, are going to be activated, okay? And they're going to then transmit that pain signal from my periphery up to the central nervous system. Okay, so I got to somehow get what happened here to my brain so that it can recognize that I have pain, so that I can remove, if you stick your hand on a hot stove, you don't have to sit there for 30 seconds before your brain realizes that it's hot and you remove it. It's instantaneous because that's a protective mechanism. Those nerve synapses happen really, really quickly, and that's a good thing. If we slow those down or we interrupt this on some form or fashion, then we have issues with pain control. Modulation is the kind of the highway of where when that hits the central nervous system as it's moving up or down, that to the brain, to the spinal column, to the brain to get it where it needs to be. And that's very, very simplified. And then perception, it finally reaches my brain and I say, oh, this hurts and I need to get away from it. So that 4 steps happens right now, hopefully. If you have patients that get things like peripheral neuropathy, and we've talked a little bit about peripheral neuropathy, where those nerves in that peripheral tissue are damaged, this transduction and transmission are interrupted. So they can't sense it like a normal person would, and it doesn't transmit from the periphery to the central nervous system, the peripheral nervous system, the central nervous system as quickly. And so that's why people that have peripheral neuropathy, they can't sense hot or cold. And so they say don't watch like clean warming blankets or getting hot water because they'll burn themselves because they can't sense that change. Their body isn't working through this process like somebody normal would. If you have somebody that has taking big opioid pain receptors, here's what, or opioid pain medication, here's what I want you to look at. Your opioids hit every single one of these steps. And so patients that are dependent on opioids will dull this process over time. And it makes it very hard then to control their pain because their body becomes tolerant to those pain medications and they need more and more and more to control that response. And it's almost impossible then to control their pain when they actually are injured. So opioids are gonna hit every single one of that. But look, your local anesthetic, this is like, I go in and I get a cut on my finger or my arm and they're gonna numb that area just so they can suture it. It's gonna affect your local and then transmitting it from your local to your central. Does that kind of make sense to everybody why that would be? So it's just the different types of medication that we're giving and where that hits in the pain process. General anesthetics, perception. I'm putting somebody to sleep, they have no perception of pain anymore. So I'm knocking it out, which is a good thing, right? You really want that to work when they take you to surgery. And hopefully it works a little bit after, so they can get something else on board. Okay, make sense? Makes sense. Non-opioids. You're gonna hear this term, non-steroidal anti-inflammatory drugs, meaning there's not a steroid component to them. Remember, steroids help decrease inflammation. So these don't have a steroid in them, but they still can help block that inflammatory process because they're gonna block either a receptor or they're gonna block histamine or prostaglandin production, which is the initial response to inflammation. I know you guys are like, whatever, I'll never know all this stuff. Okay. You're gonna hear COX-1 and COX-2. We use this COX-1 and COX-2 inhibitors, these first generation of NSAIDs, all the time. All the time. These are very, very, very common. Look at them. Aspirin, Advil, Aleve, Indocin, Voltaren, Toradol, Mobit. These are very common medications that we use in practice. This COX-2, the second generation, this celecoxib, we don't use this hardly at all in practice anymore. It worked fantastic for pain control, and it didn't have as many side effects, but the one side effect that it does have is it increases patients' risk for a heart attack and stroke. And to the point where the risk of giving the medication outweigh the benefit of it. So we don't see Celebrex given hardly at all. It's in rare cases where the physician feels like the benefit to the patient outweighs the risk, but very, very uncommon to see this. There's another drug on the market. So this is a safety thing. So Celebrex. This is a COX-2. There's another drug on the market market called Cerebrex, okay? This has nothing to do with pain. This is a seizure medication, okay? This is a commonly occurring, if you looked at that, tall men letters or commonly, this is gonna be on there. Because this is one that people mess up in practice. And they'll pull the wrong med, or they'll give the wrong thing, because it's a look-alike, sound-alike medication. Another reason why we want you guys to learn generic names, and why state boards will test on generic. Number one, there's 100 million more brand name drugs than there are. I mean, ibuprofen, there's a million different ibuprofens on the market. That's just a couple of them. And so you'd have to learn tenfold, although those seem to be easier to remember. Okay. Okay. These are your comments. One of the things that's gonna be important for this module is max doses that you can give, especially for Tylenol, aspirin, and then this ketorolac, Toradol. We only give that short term. We don't give that long term. 3 to 5 days, max 5 days. That's important to know. If you have a patient that comes in and they've been taking this medication for weeks and weeks and weeks, that's a problem. The side effects of the medication outweigh the benefits of the medication in long-term use. Has everybody in here taken aspirin, Advil? Even some of you probably taken a leave. Like those are familiar with you, for you guys, right? These are safe dosage ranges for patients that are taking them. Aspirin, 81 milligrams to 500 milligrams. This one is a little bit unique because not only does it have a pain or an anti-inflammatory effect, it also has a blood thinning quality to it. So the dosage is dependent on what we're giving it for. If we're giving it for a blood thinner, we give 81 milligrams daily. It's a baby aspirin a day. People take this to prevent heart attacks. You'll see lots and lots of patients come in on 81 milligrams of aspirin PO daily. And it's to thin that blood to prevent clots from forming. If they're taking it for pain control, they can go up to 500 milligrams PO every 4 to 6 hours, not to exceed 4,000 milligrams a day. That's a big dose of aspirin. Did I tell you my story about my patient that we had in the ICU? We had a little guy, he was probably 86 or 88, that came in the ICU and he was just bleeding from everywhere. Everywhere, his gums were bleeding, he was GI bleeding, everywhere. And they couldn't figure out why his coags, they drew blood, his PTINR, his coag profile was completely out of whack. But he wasn't taking any blood thinners. So everybody was like, what is going on? They thought, at 88 years old, he had developed some mysterious blood dyscrasia, and they couldn't figure out. And one day his wife was sitting at the bedside, and the physician came in and was like, okay, let's go through this one more time. Are we missing something? She goes, and they went through their meds, and she's like, no, that's what he said. The only other thing he takes is he takes 2 aspirin every 4 hours around the clock for weeks and weeks. Well, that was a problem. And so once they figured that out, they had to reverse the coagulation issues, but then they switched into something that was safer. But this is over the counter. People think aspirin is benign. It's been around since, the dawn of time. When you guys were never born where aspirin wasn't available, neither was I. Aspirin is very common, okay? And so people don't realize that there are side effects to even these very, very common medications that we take. So 4,000 milligrams a day is still going to cause your blood to thin. If you have somebody that's taking 4,000 milligrams of aspirin daily, they're going to be a little bleedy if you stick them. If you put an IV in them, they're going to bleed. If you put an NG tube down, probably going to bleed a little bit for you. Put a catheter in, you may get a little bit of blood in the urine. So watch patients that are taking aspirin like that. And you'll have older adults that will take aspirin. This is an older drug. Okay, they're much more familiar with this than they are with even Motrins and Tylenols. But we try to switch people if this is what they're using for pain control because it has the blood thinning effect to it. Does that make sense to everybody? Remember, 81 milligrams, low dose is for MI. The higher dose is for pain control. Motrin, Advil, ibuprofen, 200 milligrams PO, 1 to 2 tablets every 4 to 6 hours. Hey, Janessa, when you take ibuprofen, how many do you take at a time?
Depending on how bad I feel,
3 or 4? Yeah, yeah. There is actually an 800 milligram tablet, a high dose ibuprofen tablet that you can take. If I take 2 of those, I've exceeded the maximum daily dose. Now, does this mean that I'm gonna kill my kidneys or do something horrible? Not necessarily. If I'm taking it for a short period of time, you're okay. Didn't you, now that I'm saying this out loud, you had this whole conversation with your physician, didn't you? Yeah. If I would take 800 milligrams of ibuprofen every 6 hours for months, I can kill my kidneys. I can fry my kidneys. If I take 800 milligrams of morphine, or you would be dead. Just one time. If I would take 800 milligrams of ibuprofen for 2 to 4 weeks, I'm probably okay. Especially if you're younger. If you have, sorry. If you already have renal insufficiency or kidney damage, then I would want to be more careful with that. Because didn't you question this? Because you were taking it?
Well, mine was my gut though.
Oh.
I started feeling weird.
Yep.
It was on 6 weeks.
I'll talk about that in a second. Caldolor, you can actually give ibuprofen IV. You can give Tylenol IV too. So mainly we're doing it in the ICU or the OR. It's a huge benefit to patients for coming out of the OR. Right before we close the case, we hang IV piggyback of either ibuprofen or IV Tylenol, acetaminophen, and it actually helps with pain control postoperatively. So you may see, if anybody here like, oh, I think I want to do OR? Maybe, you don't know. Yeah, you might see this. Naproxen is Aleve, 220 milligrams, keto 1 to 2. I know people that take 2 Aleve in the morning and 2 Aleve at night. And so they're exceeding that daily dose and they'll take it long term for years on this. There's side effects to that. Long-term use of naproxen like that, overdosing of naproxen can lead to cardiovascular disease, which would then lead to stroke or MI. If I'm hardening my arteries, then I have problems with clotting. But you go buy these over the counter. Does everybody, when you buy a medication over the counter, you pull open the little packet that's in there and you read every side effect to it? You don't? Right. Because it's safe, it's over the counter, it's a safe medication, but they're not always as safe as what people think. There's side effects to them. Indomethacin is Indocin. This is usually prescribed on a longer term basis to patients that have chronic pain issues, so 20 to 50 milligrams POTID. This is a safer one to be on long term. Diclofenac or Voltaren, this is new on the market, and you can actually have it in an extended release tablet or a pain cream. So you can buy it, and it can be a topical, which is the pain gel. What does extended release mean? Over longer period of time. If I'm gonna give somebody some education on extended release tablets, what would I wanna tell them? Do not do, and I want you, when you do it, please do this. When you teach that patient, no, please don't. Yeah, don't finger in the face, yes. But explaining then why, because you get the dose quicker than you should get it. You should let it dissolve in your stomach. So you guys learned something. That's the question I need to put on the test, right?
Yes.
That's an easy point.
That's an easy point. Those are good bonus questions. Contourlet or Toradol. It is awesome. It actually works really, really well. But we only want to give it a few times. Sometimes post-operatively, they will give 60 milligrams of Toradol, IV push, every 6 hours times 3 doses. That's a common order that you'll see for Ketorolac or Toradol. We can give it IM if we need to. Did you get yours IM? Did you give it to yourself?
No,
Just when you were in this hospital?
well, I got it before the hemorrhoid
Okay,
to chill everything down.
to chill everything down. Okay.
It was rough hair. And it
Shots,
hurts.
shots hurt, shots hurt, shots hurt. The most common type of injection that you guys will ever give in practice is a vaccine. We don't give a ton of IM injections anymore. Occasionally in the ER they still will, when people come in so they don't have to start an IV on them. But most often we're giving medications IV. Remember, if I give it IM, it absorbs slower and works longer than if I give it IV. Acts quick, but it shortens the half-life of the drug, depending on the route that I administer it. Does that make, so oral medications take the longest, but they tend to work the longest. IM, work a little quicker, lasts a little less. IV works quick, gets rid of it quick. IV pain medications work great for patients. PCAs are fantastic. We'll talk a little bit about PCAs later here. We want to get people off of IV pain medication. Number one, we can't usually send them home on IV pain medication. There's rare instances where we do that, hospice, things like that. But we don't like to send people home on IV. And it is this, it's a, and so we want to even that out. And so we want to get them to oral medications because it actually has if you give it every 4 to 6 hours, you maintain that level in the system versus the IV, and then come down and then I have to get it again, and then it comes down. So oral routes work longer. Meloxicam, Mobic, is another medication that you'll see people on long-term oral. So Indocin, or indomethacin, and meloxicam are the two that you tend to see people on long-term. I'm gonna back up one thing. People that are in renal impairment, we have to dose of Toradol. Instead of 30, we go to 15. Because of the effect that it has on kidneys. The COX enzyme is what produces those prostaglandins that promote inflammation. So that first slide that I had that had the inflammatory process that talked about the release of histamine and prostaglandins, the COX enzymes are what produce that prostaglandin. So these COX-1 and COX-2 inhibitors inhibit that prostaglandin and then halt that inflammatory cascade. But they also inhibit platelet aggregation and can cause kidney damage. And so we gotta watch the renal impairment, we've gotta watch for cardiovascular disease in patients. Okay? They suppress inflammation. They can also, because part of the inflammatory response is if your body senses that you're having some sort of inflammatory response, even if it's localized, if you have a cut and you have a red raised inflammation, if you feel that, it's warm, right? It produces warmth because those capillaries dilate and they come to the surface and it causes that warmth in that area. Bacteria and pathogens do not like high temps. That's why our body runs temps, because it's a natural mechanism to help kill off or help the process for bacteria to not multiply and spread. They don't like that. They don't like really hot. They don't like really cold. So if it's localized, you may feel the warmth at the site. If it's systemic, you may run a fever. If you have an infectious process, y'all run a fever, and it doesn't feel great. You usually get body aches, headaches, just feeling generally not good. But if somebody is running a low-grade fever and they can tolerate it, that's a good thing. You don't necessarily want to go in and medicate them for fever because it's going to be it's your body's way of helping to fight that infection. So unless they're very uncomfortable, or in an adult if it's greater than 101.5 or 102, then we want to let it ride. And that goes against everything you've ever been told and everything that you've ever heard or felt. But we tend to not want to do that in practice. Okay. The stroke and aspirin is the one that kind of does the opposite, okay? Every other one of those can cause risk for cardiovascular disease. Aspirin actually is the one that thins the blood. So we use this to prevent that. Okay. Big complications of NSAIDs, GI upset. Big time. Has anybody ever taken ibuprofen on an empty stomach? What does it make you feel like, Leah?
Like my stomach is burning a hole.
Yeah. Yeah. Literally can cause GI ulcers, so that's a real thing. But so burning, pain, sometimes people get sharp, stabby pain, or just super nauseous, like pukey, sick, because it's so hard on the system. So if you can take these with a little bit of food, even if you're just taking it with like some crackers or something like that to help get that through your system, this is one medication that it's okay to take with food. You want to do that. You don't want to take it on an empty stomach. And I've talked about the next couple, the impaired kidney function. These are meds are hard on your kidneys. You guys know have you guys talked about labs at all? Some? Do you guys know what your labs are for kidney function? Does anybody know what your labs are for kidney function? Urinalysis is to determine if you have infection in or what's in your urine, but there's better ones that monitor kidney function. Creatinine is one of them, and BUN, your blood urea nitrogen, is the other one. So BUN and creatinine are the labs that we monitor for kidney. BUN typically, if their BUN is elevated, it typically shows us if a patient is dehydrated. If a creatinine is elevated, that's more indicative of kidney failure, but they're reported out together. And it's part of your basic metabolic panel, if you care.
Isn't the GFR for kidney function?
Mm-hmm. Your GFR, your glomerular, I had to say that slow and get it all in, filtration rate. So, you have that glomerulus in your tubules and your nephron in your kidney, and your glomerulus is what filters electrolytes, fluids, particles, whatever, out of your kidneys. And if your kidneys are failing, the glomerulus filtrates at a much lower rate than what it should. And so your GFR can actually indicate kidney failure as well. And when we talk about putting patients on dialysis, we base it off of the GFR, the glomerular filtration rate. And that labs will come back. Labs will come back over and over and over again. Ask the seniors, they love labs right now. Labs and meds come back. If somebody had kidney failure, what might that look like? And I know you guys haven't done kidneys in patho yet, but what do your kidneys do? What does your kidney do? Kidneys. It helps filter blood. It helps filter the toxins from your body, right? Yep. What else does it do? What else is it important to do? Huh? Urine output, fluid. It regulates the amount of fluid in your body. So if your kidneys aren't working and I can't get rid of fluid, where is it gonna go? Everywhere. Yeah. That's when, if your kidneys start to fail and you can't filter fluid or you can't get rid of fluid and you hold on to fluid, it's gonna end up in your interstitial spaces. That's why you get edema, like that edema that you'll see in patients' extremities. Or even worse, it builds up in their lungs, in their abdomen, and they'll get things like pulmonary edema or ascites in their abdomen. So you have fluid in compartments of your body that it shouldn't be. If I can't filter toxins from my body, I can get big buildup of electrolytes or ammonia or things that I don't want high levels of in my blood. And you can have all kinds of different side effects depending on what it is that's out of whack. If I have patients with kidney failure, one of the biggest things that happens is their potassium levels goes through the roof because your kidneys won't filter that. And if I have too much potassium in my blood, it can stop my heart. So I need to make sure that that happens. And we're doing something about it, whether it's giving them medications to help their kidneys function or dialysis. Aspirin toxicity is a thing. And you'll see a lot of neuro effects with aspirin toxicity. You can get nausea, vomiting, diarrhea sometimes. You can get bleeding for sure. But aspirin at really, really high levels actually causes patients' neuro status to change. So they'll start to get lethargic and moving clear into coma if I don't reverse it. And then Rye syndrome, aspirin given during a viral illness. So we see this most often in pediatric patients. And if you have a child that has a pediatric viral illness, you absolutely don't want to give aspirin to them. We tend to not give aspirin to kids at all. It's not a pediatric medication. Chickenpox is a viral infection. You guys, most of you have been vaccinated, if not all of you have been vaccinated against chickenpox now. But some kids still get it, and you don't want to give them aspirin. You want to educate parents to not give them aspirin. They can have Tylenol, and they can have Motrin, but they cannot take aspirin. RSV is another big common pediatric illness. It's a respiratory virus that kids can get, and we would not want to give them aspirin during that because it can cause Reye syndrome. Oh, there's your B unit credit. I used to flip the slide fast enough, sorry. I asked it on the wrong slide. It's there. I know what's coming. Contraindications for NSAIDs. Some of these you guys have already talked to me about. Peptic ulcer disease. If I have GI ulcers, I don't want to take NSAIDs. I can exacerbate those. I can make them bleed even more. If I have a bleeding disorder, aspirin and NSAIDs can make those even worse. Avoid in pregnancy. We don't give any of these medications during pregnancy. During pregnancy, you can take Tylenol after the first trimester. That's about it. So if you get sick and you get a headache, you maybe can take some Tylenol, or you just suck it up. Yeah. And we're not protecting mom during that time. We're protecting baby. So there's a whole list of medications that you cannot take when you're pregnant, and NSAIDs are one of them. What are some of your anticoagulant medications? Think back to hematologic system. Heparin, warfarin, Lovenox. Clopidogrel is an antiplatelet. Your anticoagulants like warfarin, just count that is going to be one that you can't take with any. It's like interacts with almost everything. That's why we have better options for that now. Glucocorticoids, these are your steroids. These are like Solumedrol, prednisone, Soluporta, methylprednisone, prednisolone, medications that are going to suppress that inflammatory response, but they are super, super hard on your stomach too. So if you have a patient that is on both an NSAID and a steroid, you need to make sure that you're giving them a medication to help prevent ulcers. So there are your ones that are gonna be on like your Pepcid, Protonix, Prilosec, because of the risk of getting the GI ulcers. Alcohol thins your blood. If you didn't know that alcohol thins your blood, alcohol thins your blood. I'm telling you now. And just so you know, alcohol doesn't mix well with meds. So it's another one that if you see a med drug or a question on a test and they say, what should you not take with this drug? Alcohol is probably the right answer. You shouldn't drink and take meds together. That should not happen. Okay? But one of the things that alcohol does is it thins your blood. So you can actually make somebody even a higher bleeding risk if you are giving an alcoholic some of these medications. Do not take ibuprofen with aspirin. Aspirin loses its antiplatelet effect. So this is important if you have somebody that is on a low dose aspirin for prevention of MI, right? If I have somebody that they're taking 81 milligrams of aspirin PO daily to prevent MI, and then I don't educate them that if they take Motrin over the counter, that I eliminate or get rid of the benefit of taking that aspirin. So they should not be taking other NSAIDs when they're on that low dose aspirin for MI prevention. Toradol is a one and done. While they're on Toradol, they cannot take any other NSAID. We do it for a short period of time, remember only 5 days, and then could move them to something else, but while they're on Toradol, that's it. They don't get anything else besides Toradol. Break. Get up, move around, take a break. It's Monday. I'm gonna pause this, but will you restart it?